So today we're going to be talking about the musculoskeletal manifestations of systemic sclerosis. So we're not going to be talking about this guy's musculoskeletal system, but we are going to be talking about the musculoskeletal system and how can it be affected by systemic sclerosis. So a couple of different parts of the musculoskeletal system and how it can be affected. The joints can be involved. And I'm going to make the distinction between arthropathy, which is a more general term. Opathy just means disease of. So this is a very general way of saying some disease of the joints. And arthritis, where that itis really means inflammation of the joints. And that distinction helps us approach disease of the joints in different ways. So arthritis is inflammatory arthropathy, okay? And then the muscles can be involved in systemic sclerosis too. And similarly, we can see myositis in scleroderma, which is a real inflammation of the muscles. And we can also see myopathy, which is a more general term, meaning disease of the muscles. So it would signify something that's less inflammatory when you talk about myopathy. The bones can be involved too, and I'm going to show you what something called Accra Osteolysis is. And another way that they're involved in systemic sclerosis and other rheumatic diseases is by osteoporosis. And even though that can affect anybody, that's something that specifically we should think about in systemic sclerosis too. The tendons can be involved in systemic sclerosis. They're very closely linked to the joints. So we can have disease of the tendons and tendon friction rubs, which we'll go through in a little bit more. Disease of the tendons can lead to flexion contractures, which are when the joints get fixed in a flex state. And Kalsa Gnosis is another way that, another painful condition that affects systemic sclerosis. So I'm going to be talking about a lot of different ways that, that the musculoskeletal system is affected. One who has involvement of their musculoskeletal system has different symptoms. So they can experience all these different etiologies as pain or discomfort. Stiffness may be the way someone describes it. Weakness is seen. We can see decreased range of motion and overall decreased function. And a lot of these musculoskeletal system manifestations also influence fatigue, and I think that's part of this too. And these types of manifestations are associated with depression, anxiety, they decrease quality of life, and they lead to increased disability. So these are really important parts of scleroderma. So first let's talk more about joint and tendon involvement. So in scleroderma, arthropathy contributes to disability. We see arthritis and tendinopathy in systemic sclerosis with variable prevalence, meaning depending on the study, we see it affecting different proportions of patients with systemic sclerosis. So some studies show it affecting 24% of patients, and others show up to 97% of patients sometime during the course of their illness having their musculoskeletal system affected. I tend to think it's towards that upper range. And there are different ways we see it involved. So we can see inflammation of the joint lining or synovitis, joint contracture, and tendon friction rubs. And these manifestations are associated with early disease, disease severity, and higher degrees of systemic inflammation. Joint synovitis, this inflammation, and tendon friction rubs are actually independent predictive factors for disease progression when they're seen in early systemic sclerosis. So even beyond the way they affect the joints and the way they contribute to disability, they show even a broader meaning that a patient who has a lot of arthritis and tendon friction rubs is more likely to have severe systemic sclerosis. And this involves disability, impaired quality of life. But even though we see this so frequently and it's so important, actually the treatment of arthritis in scleroderma is not something that we generally address in our clinical trials. We do tend to focus a lot on lung disease and skin disease, but arthritis isn't developed in the setting of clinical trials. So this is a direction that I think is very important for us researchers to take. This is a picture of a normal joint. And I just want you to kind of get a sense of what I'm talking about when I talk about the joint. So these are two bones that come together and make up this joint. And those bones have a layer of articular or joint cartilage. And that cartilage preservation is very important for the bones to move near each other without hurting. Below the cartilage is subchondral bone plate, and then this is the fibrous joint capsule. And then inside there, you see the synovium, or the lining of the joint, and that is an area of the joint that can where you can see a lot of inflammation. So when you hear the term synovitis, we're talking about inflammation of the synovium. And then this is a muscle here, and that muscle attaches to the bone via a tendon. And so you see that here. So now you're oriented. And this is a picture of a photomicrograph, or a photograph of what's seen in a microscope. And you see it sort of looks like that diagram I showed. So here is the cartilage, and then the subchondral bone, the joint capsule, and the synovium. And this joint is affected by osteoarthritis, so we see some wear of that cartilage, and this is a bone spur or osteophyte that you see over there. And then here we are back just orienting ourselves. This is what the joint looks like when you look at it on X-ray, so that you're still seeing that you see more the joint space here. You don't actually see the cartilage there. You do see the subchondral bone. So in an X-ray, you don't really get a very good view of any of the soft tissue structures of a joint. You really only see the bones. If you want to get a better sense of the soft tissues of the joint, you can use an ultrasound. And this is a picture of an ultrasound. And you have to be very highly trained to be able to read these well. So now we're on the side, and this is a bone here, and this is a bone here of the finger, the distal phalanx and the middle phalanx, and here's that joint space. Okay. And then this is a picture of an MRI. So you can see that you get a lot more resolution when you're using an MRI than an X-ray or an ultrasound. So these are very sensitive, and you can see soft tissues here. Other terms that we use in joint involvement, arthralgia just means joint pain. Arthritis, as I said before, signifies real inflammation, and arthropathy is a general term meaning any disease of the joint. Synovitis meaning inflammation of the synovium, that's something seen, and a rheumatologist means inflammatory arthritis when they say synovitis. And then, but joint involvement also includes those tendinopathies, tendon friction rubs, and joint contractures. The arthropathy that's seen in scleroderma is a really deeply fibrotic process, and it involves the joints and the tendons. These are some pictures of my patients. This is a patient with more early scleroderma where you see a lot of swelling and puffiness. There's fluid or edema in the tissues, but there's also the start of fibrosis here. And this is one of my patients who's had scleroderma for some time. But there can also be a superimposed inflammatory process in these joints too, and that may be more responsive to any inflammatories or different approaches that we take in treating other kinds of inflammatory arthritis. This is a picture of a normal x-ray just to orient you. I want to just give you a sense of the way we see pathology. This is a picture of one of my patients with systemic sclerosis who has severe hand contractures. So you can see that she wasn't able to extend her hand in this way. This is another photograph of hand contractures and yet another one as they've progressed. But other conditions, and I just want to give a sense of this so we can talk about overlap with scleroderma, other conditions can lead to joint contractures and hand disability too. So this is a patient with rheumatoid arthritis, also who's developed hand contractures and other deformities of the hand because of her arthritis. And then this is somebody with osteoarthritis or degenerative arthritis of the hands, and you can see that can also lead to deformities and contractures. This is erosive osteoarthritis, so on the severe end of the spectrum. And, you know, this is the kind of thing that is very common, actually, and can also affect patients who have scleroderma because it is a common thing that happens in the hands. So that can be part of hand disease or joint pain in systemic sclerosis. This is a photograph of what that person's, x-ray of what that person's hand might look like. This is another one of my patients, and this patient really has scleroderma and rheumatoid arthritis together. And you can see what I mean, I think, when I talk about synovitis. When you look at the degree of swelling here at the hand, in these joints of the hands, the MCP joints, you can see a lot of swelling. So that's a clinical finding of synovitis. And then her hands, you can see instead of being contracted like this, she has this sort of zigzag, and so we would call that a swan neck deformity, and that's seen in rheumatoid arthritis, but she has clear scleroderma too. This is a different patient with early scleroderma who has the very early scleroderma, actually, just a few months, but he's already developing these hand contractures from from this deeply fibrotic process. And whether there's some degree of inflammation there too is a question that we have. So how do we figure that out? We do some laboratory investigations, and sometimes they help. A rheumatoid factor is seen in about 30% of folks who have systemic sclerosis, but this is very nonspecific. So having the rheumatoid factor doesn't really say that you also have rheumatoid arthritis too. It's just something that we see a lot of folks with inflammatory conditions can have this. On the other hand, a CCP antibody or an ACPA is associated with the development of inflammatory and erosive arthritis and systemic sclerosis. So a lot of times we'll say a patient clearly has systemic sclerosis, rheumatoid arthritis overlap if the CCP antibody, which is highly specific, is positive. But does that mean that only those patients have inflammatory arthritis? So I'll try to get to that. I don't think so. I think other patients with systemic sclerosis, even if they have a negative CCP antibody, do still have inflammatory arthritis. Another way we can look at it, and the rheumatologists check these all the time, is by looking at the SED rate and the CRP, and that's sometimes associated. Those reflect inflammation in general and can signify joint issues as well. If you have a very swollen joint, we could take a needle and pull out fluid from the joint, and that may reflect inflammation. And when that's done in patients in systemic sclerosis, when they have an effusion, you can see that there are features of it that may be inflammatory. And synovial biopsies were done, and that means we take a sample of that joint lining in systemic sclerosis has been done in the setting of a study. And that did show some degree of inflammation, but to a lesser degree than rheumatoid arthritis. So we can use our radiologists and do some additional testing. We can look at x-rays that show some features. They don't usually show erosions unless it's really more severe. An ultrasound and an MRI, as I showed you in those pictures, are more highly sensitive to picking up inflammatory change. So in this study, ultrasounds were done in systemic sclerosis patients who had joint pains, and it was compared to the clinical exam by the rheumatologist. And the ultrasounds were shown to be much more sensitive in picking up joint inflammation or synovitis than clinical examination. So I think those are something that could be used. MRIs are even more highly sensitive. And in this photograph, we see a couple of series of MRI pictures that show erosions and inflammation of the joint lining. And you can see in both on the MRIs and systemic sclerosis these findings of inflammatory arthritis. And these patients didn't have the CCP antibody. So in scleroderma, you still see some of these inflammatory features.
Could you point to something there?
Sure. So in this is an MRI. And this is one of the bones of the wrist here, the scaphoid bone, and you can see erosions here. I'm going to show you one other picture. This is another MRI photograph. This is from one of my patients. And in this MRI, the white means different things. Here, the white is showing the bone, and in this soft tissue, it's showing inflammation in the soft tissue. And you can see inflammation here in his lumbrical muscles, and you can see actually inflammation in the different soft tissues as well. So this is a very abnormal looking hand here. That's Phil Clements. All right. So looking at low field MRI in patients with systemic sclerosis also showed erosive arthritis. So these were patients with joint pain, but they saw a lot of these more. When we talk about erosions, it signifies a more aggressive kind of arthritis. And the overall message of all the stuff I'm showing is to show you that really arthritis, this inflammation, is present in systemic sclerosis too. And it's not only scarring that affects the joint. So what about the tendons? Well, they're involved in this process too. And we can see tendon involvement in about 36% of early diffuse scleroderma patients. And overall, it's been considered to be seen in 20% of patients. It can occur in multiple joints. And it can lead to additional problems besides contractures. So in the wrist, it can lead to carpal tunnel syndrome. And going back to our picture, so here's our tendon, and you can see how closely associated it is and how it would affect the joint as well and lead to arthropathy. Tendon friction rubs are a finding in a subset of patients. These are palpable. When you move the joint, you feel friction. It's described in different ways. Some people feel like there's Velcro or like poppy paper, or a squeakiness I've heard described. And these are also associated with disease activity and severity and can be a predictor of diffuse disease when seen very early, and are seen in different patients. So in this study, MRIs were done on patients who had tendon friction rubs, and what they were able to see is right next to the tendons where the tendon friction rubs was high signal on the MRI, and so an inflammation right next to the tendon, and it gets to the point that I think we may have felt that these tendon friction rubs represent an inflammatory process going on right there around the tendon. I'm going to switch gears a little bit and talk about Kalsa Gnosis, which is a very sort of different manifestation. It causes pain, can lead to infection and disability, and calcium crystals deposit in the soft tissue, and they can occur in many different places. We see them in the hands, wrists, elbows. They've been seen in the gluteal region. Less commonly, they're reported in the spine. It occurs in about 25% of patients and can be associated with digital ulcers, and it's also been seen to be associated with osteoporosis as well. And there's a lot we don't know about Kalsa Gnosis, but some contributing factors are inflammation and hypoxia, meaning not enough blood flow getting to a certain area. This is a picture of an X-ray of the hand where Kalsa Gnosis is seen. And you can see these huge calcium deposits here. And another feature here on this X-ray is Accra Osteolysis, which is from repeated low blood flow to the tips of the fingers. There's resorption of the bone, and that patient would experience it as some shortening of their fingers. So you can see that association here. This is a patient of mine who has Kalsa Gnosis, and on this picture you just see a bit of it coming right through the tip of her finger, and then this is her X-ray, which I think is very dramatic, which shows these deposits of calcium in the hands. And I'm always amazed by my patients. I'm particularly amazed by her because she just truly doesn't complain at all and just manages with this. She's extremely stoic. And she says it really doesn't cause her pain, that she's not being stoic. But I don't know if I believe her. This is another patient of mine, and we had done this X-ray of her foot for a different reason. She had injured it. And I showed her the X-ray, and I showed her the Kalsa Gnosis right here, and she's like, that's where my foot's been bothering me. So it's been making her crazy. In any case, you can see these different ways that you can see it. And sometimes a tiny Kalsa Gnosis can cause tremendous symptoms, and sometimes larger ones are relatively well tolerated. The treatment of Kalsa Gnosis is a huge challenge. Because we talked about poor blood flow as possibly a contributing factor, we try to pay attention to that with treatment and do whatever we can to improve blood flow. So a lot of times those are similar treatments to what would be used in Raynaud's, like calcium channel blockers or other kinds of medications that may be used. As needed, antibiotics, if there's infections, and wound care and supportive therapies are extremely important. And then excision can be considered if there's infection, severe pain, or functional impairment, but it's not a curative procedure. Kalsa Gnosis can reoccur in the same area, which is a very frustrating thing. A lot of my patients who suffer with Kalsa Gnosis just want it cut out. But they can be complicated surgeries because the Kalsa Gnosis can go very deep and can involve deep tissues as well. It's not always a superficial or a well-confined area, so the surgeries can sometimes be complex. So there are many medicines that have been considered for Kalsa Gnosis. Sometimes calcium channel blockers are used, and there's reports on that helping, maybe because of the improving ischemia. Bisphosphonates have been used, and there are just reports in the literature that sometimes they're helpful. There's no definitive studies been done, and my clinical experience is that these are not always helpful. Low-dose warfarin has been used to different degrees of success reported in the literature, none definitively, and again, I think the general experience with it is rather lacking. Sodium thiosulfate is sometimes tried, either intralesional as a little injection or given as a cream or even IV. It can be given with variable reports on success. Colchicine and Minocycline have been used to reduce inflammation, and they may be helpful in pain, but not in making the Kalsa Gnosis go away. And then there are case reports of IVIG, infliximab, or Remicade, or rituximab being helpful, but these are all just real questions and nothing definitive here, with kind of low-quality evidence in the literature, meaning that one person reported one case or two cases, so it's not enough to give you a definitive answer about using them. Bone involvement, we talked a little bit about Accra Osteolysis, and then osteoporosis is another way that the bones can be involved in systemic sclerosis. Osteoporosis is common, and it occurs most commonly in postmenopausal women. So after menopause, primary care doctors and gynecologists know to order these tests as screening. It's not always thought of in men, and it's something to be considered, especially in men who have inflammatory disease, who've been treated with prednisone or corticosteroids, who may have low testosterone. These are all different things that osteoporosis should be considered in men too, and should be screened. And it's a relatively simple test to do a bone density. Different reports on the prevalence of osteoporosis and scleroderma. So I'm showing you one that shows 3 to 51%. That's a huge variety of different studies that show it. But in other studies, they looked at patients with scleroderma and compared them to age and sex-matched controls, and osteoporosis was more common in systemic sclerosis. There are other risk factors that contribute to osteoporosis. There are many, but some of them are low body weight and age. And this, in one study done recently, was seen to associate with Kalsa Gnosis as well, but we don't know the reason for that. Treatment is calcium and vitamin D, bisphosphonates, which are medicines like Actonel and Fosamax, selective estrogen receptor modulators, parathyroid hormone, or Forteo is the brand name, and denosumab, which is also known as Prolia. These are medicines that are available to anybody who has osteoporosis, and folks who have systemic sclerosis can take them too, and they help for osteoporosis. The only caution I would say with these treatments is that, or one important thing to note that affects a lot of folks with systemic sclerosis have esophageal problems, severe reflux, or difficulty with the motility and movement of the esophagus. So taking oral or by mouth bisphosphonates can be very abrasive to the esophagus, so sometimes the oral form of those medicines isn't going to be appropriate with somebody who has severe esophageal disease. Muscle involvement can be seen in systemic sclerosis as well. We talked about myopathy or muscle disease versus myositis and muscle inflammation. And a subset of patients with systemic sclerosis have real powerful inflammation in the muscles, or myositis, and that can look very similar to polymyositis. In fact, there's a PMSCL antibody, which a subset of patients have, which is seen in, again, a group of the patients who have this polymyositis and systemic sclerosis overlap. But there can also be a non-inflammatory bland myopathy that's seen in scleroderma too. And the estimates are that myositis is seen in about 10 to 15% of patients with systemic sclerosis. That prevalence of that non-inflammatory myopathy is really less clear. It's a little bit harder to assess that. But myopathies in general are more common in patients with diffuse scleroderma. The way they're experienced, the symptoms that patients have are weakness in the muscles, especially weakness in the proximal muscles, so the upper arms and the hip flexors can be seen. So they may have a difficult time lifting their arms all the way up or getting up from a low seat. One screening test that's done is with blood work, where we can see muscle enzymes called creatine kinase or CK and aldolase, and there are others as well. Sometimes an EMG may be needed. MRIs can also show muscle inflammation. Sometimes muscle biopsies are needed. Sometimes they're not to direct therapy. And it is important to note that these patients who have myositis can also have a higher risk of cardiac disease. So when I see my patients with myositis, I think about that and just make sure I get an EKG, and I usually try to do that anyway, and an echocardiogram to know if anything's going on there. In a survey of 1,100 patients with systemic sclerosis, about almost 6% had a high CK, and the other associations with this elevation in the muscle enzymes were male, having diffuse systemic sclerosis, having tendon friction rubs, having a low forced vital capacity, and patients were seen to have the RNP, or the topoisomerase antibody positivity. And these patients actually had decreased survival in this study, and that was because they had some concomitant interstitial lung disease, cardiac involvement, or pulmonary hypertension. So there may be an association with myositis and myopathy and more severe systemic sclerosis. One interesting aspect is that patients with inflammatory myositis tend to improve when we treat them. And the treatments for myositis are similar to the treatments that are used for myositis that isn't associated with systemic sclerosis. So those include corticosteroids like prednisone, methotrexate and azathioprine. IVIG is sometimes considered, and then there are other therapies as well. But therapies are available to treat myositis, and patients tend to improve. And still talking about myalgia and muscle symptoms, but now more pain in the muscles, is a totally different condition. And this is something called fibromyalgia. This is a common condition. It can be seen in anybody. You don't have to have scleroderma to have fibromyalgia at all. It's seen in about 2 to 3% of folks in the U.S. And it is the most common cause of generalized musculoskeletal pain in women between 20 to 55 years of age. It's experienced as a chronic, widespread musculoskeletal pain. So patients will say, I have pain from the top of my head to the tip of my toe. It's very diffuse. It's hard to make it more specific for them. It can be accompanied by overwhelming fatigue, memory disturbances, and there are a lot of associations with fibromyalgia. So folks who have depression or anxiety or other psychiatric issues, and they may have other kinds of physical ailments like irritable bowel and interstitial cystitis and headaches. It's not really known why people have it, but it's thought that it's a disorder of pain regulation and central sensitization to pain. And again, it can be associated with other conditions that cause musculoskeletal pain. So we see it in patients with rheumatoid arthritis, lupus, and all other kinds of inflammatory conditions as another layer of pain. It's also associated with disruption of sleep. So sometimes people who have sleep apnea or restless leg syndrome can have it. And sometimes people who have again, anxiety, depression. These are also things that can affect sleep. Post-traumatic stress can have fibromyalgia too. So I went through some of these symptoms. And so pain can occur in scleroderma for multiple reasons. These musculoskeletal issues that we talked about, Raynaud's and digital ulcerations, Kalsa Gnosis, GI issues, these all cause pain. And in one study, 85% of patients with scleroderma reported pain. So that's a very significant aspect of this condition. But fibromyalgia is one of these other things that can affect patients with systemic sclerosis. And it becomes very important in treating pain to be able to distinguish fibromyalgia from other disease manifestations. So this is one of these areas that we have to try different things and try to tease it out. And it can be a little bit complicated, but there are non-pharmacologic measures to treat fibromyalgia, like improving exercise and improving sleep. Sometimes these things are easier said than done, but when you increase exercise, you can actually improve the structure of your sleep. So we see improvement in symptoms of fibromyalgia when those measures are taken. So that means addressing, with sleep, it means addressing the underlying causes of why you're not sleeping, which can be complex. There are medications that can help with fibromyalgia, different kinds of antidepressants and antiepileptics like gabapentin or Neurontin or pregabalin or Lyrica can help too. So there are treatments available. And so now I want to go back and talk more about overall treatments for the different kinds of musculoskeletal manifestations of systemic sclerosis. So like I told you when we started out, this is an area where we need a lot more research, certainly, and we need improved abilities to study as well with good clinical endpoints for studies to be done. And because we're not quite there yet, we haven't performed randomized controlled trials specifically for arthritis, but we are studying outcome measures and we are looking more into this. But just the fact that there are no trials doesn't mean that there are no treatments. A lot of the medications that are used to treat other kinds of inflammatory arthritis are very successful in systemic sclerosis patients, but this does wind up being one of those areas where we need to try this and see if it helps and try that and see if it helps. So it winds up being a place where you would, somebody who's affected with this would really need to work closely with their rheumatologist. So the first thing I want to mention are non-pharmacologic therapies like occupational and physical therapy. These are really key. The occupational therapists are hand therapists. The physical therapists will, and the OTs will do more fine motor, like hand and wrist issues. The physical therapists do more of the bigger joints, shoulders, knees, hips, those kinds of things. With OTs, folks here may have gone to OTs before. Paraffin wax, stretch and strengthening of the hand and face, massage, and can be very helpful. The OTs that I work with also try to develop home programs for our patients with goals for our patients to do at home, because it's different when you're doing therapy for a chronic illness. A lot of times physical therapy is for an acute injury. You broke your leg or you hurt your knee or something like that, and there's sort of a discrete period of time you have to do therapy for. But in scleroderma, this is a chronic illness, so a lot of times we need extended periods of doing therapy. So it's very important to learn these exercises, do them at home, and have goals that you do at home. It's an everyday thing. It's not a just once a week for half an hour kind of thing. It's also a little inconvenient to have to go to therapy. So I think these home programs make working exercise in a lot more convenient. Anti-inflammatories, now switching to pharmacologic therapy. So there's a lot available. I'm going to go through this in sort of a general way. Non-steroidal anti-inflammatory drugs are, or NSAIDs, are available over the counter or by prescription. So over the counter, you've encountered ibuprofen or Advil or Motrin, naproxen, which is also sold as Aleve, and prescription strength ibuprofen and naproxen are available as well as a variety of other nonsteroidal anti-inflammatories. The caution with these medications are that they can lead to GI issues. So if reflux is a big problem, these medicines may not be well tolerated. They can increase risk of GI bleed as well. So if you have watermelon stomach or gastric antrovascular ectasia or GAVE, it may be problematic to use these medicines too because it's going to increase risk of bleeding. And there are cardiac and renal and sometimes hepatic issues or liver issues with these medicines too. So even though you can get them over the counter, they can cause some significant problems, and whether they're going to be appropriate for you would be something to talk about with your physician. But these can be very helpful in symptom management, and they're available. They can make a big difference. Steroids are sometimes used too, prednisone or methylprednisolone, or also known as Medrol. These can be very useful in inflammatory arthritis and very, very helpful in myositis. And they're helpful also in figuring out, I told you that challenge about figuring out whether it's arthropathy or arthritis. Sometimes just looking at the effect of a little bit of low-dose steroid can be very helpful in teasing that out. But again, nothing, prednisone and steroids are truly a double-edged sword for everybody, but especially in systemic sclerosis. So in systemic sclerosis, prednisone at doses higher than 15 milligrams daily have been associated with an increased risk of scleroderma renal crisis. So we're very judicious about dosing these medicines. It's probably okay to use 10 milligrams of prednisone, but it's not for a long term, and because of other side effects too. Osteoporosis, high blood pressure, diabetes, all kinds of things. I sound like one of those commercials. But the renal crisis is the one caution I really wanted to get across. Methotrexate may be considered first-line therapy for arthritis and systemic sclerosis. This is medicine used also first line in treating rheumatoid arthritis in many patients. It's been studied for scleroderma skin disease. It's helpful in inflammatory arthritis and in inflammatory muscle disease as well. Methotrexate is definitely something that can be considered. In terms of side effects of methotrexate, it's taken weekly, and a lot of my patients will feel very tired that day or the next day. Can have some GI side effects like stomach upset, and the liver has to be monitored very carefully when you're on this medicine, as well as blood counts. And it does affect the immune system, so if you're on it, there's some increased risk of infection. Methotrexate is also something that has to be very carefully considered in women who may be at an age where they're considering pregnancy. It is completely contraindicated in pregnancy. It leads to birth defects. So it's something you have to be really careful with. It's also very, very long-acting medication. So I like to see my patients off of it for 6 months before they'd even think about conception. And alcohol is generally to be avoided when you're on this medication. But it can be very helpful in treating these musculoskeletal conditions. So I told you all the bad things, but there are good things too. It helps treat arthritis. Hydroxychloroquine is another medication that is used very commonly, and there is so little in the literature about the use of hydroxychloroquine in systemic sclerosis. I'm citing a paper here which when I was looking up to see what studies do we have in systemic sclerosis and hydroxychloroquine, I found this one, which was a survey of experts, and they asked what do you use to treat arthritis? And if methotrexate doesn't work, a lot of people noted that they would use hydroxychloroquine. And there wasn't a lot more. But this is a medicine we use all the time in the treatment of lupus-related arthritis and rheumatoid arthritis. And it's one that rheumatologists generally have a lot of comfort with because although it affects the immune system, it doesn't suppress the immune system. And so you're really not at risk of infection when you're on this medication. It's generally pretty well tolerated, sometimes a bit of nausea, occasionally someone will have a rash. And then there are some important long-term toxicities of the medicine. So if you're on it for many, many years, you can see issues in the eye, in the retina, and an ophthalmologist would need to monitor anybody on hydroxychloroquine. And you can also see deposition in other areas too. So it is, I think the medication does have long-term toxicities. So when I use hydroxychloroquine to treat my patients with any condition, but specifically those with scleroderma and arthritis, I really want to ask the question, is this medication helpful? And again, this is one of these things where it's a try and see sort of approach. So I usually set it up and I say, let's give this one a try. We're going to give it 3 to 6 months because it's slow to act. And we're going to see how it impacts joint pain specifically. I don't have any expectation that it's going to help skin, or I have no expectation that it would help their lungs or anything like that. It could help joints. Maybe it would help some muscle symptoms too. So we try and we define a period of time, and if it's helpful, then I think it's worth the potential long-term toxicities. But if it's not helpful and we stop it and my patient feels exactly the same, then it's not worth any kind of risk of long-term toxicity.
Is that Plaquenil?
That's Plaquenil, sorry, yes. IVIG is another medication that I just want to mention. Different small studies have described improvement in skin or GI. It's used in inflammatory myositis and multiple different conditions. And one study showed a beneficial effect in Scleroderma-related arthritis as well. And so it is something to be considered. IVIG is not an easy medication to take, or IV immunoglobulin. It's a blood product, actually a pooled blood product. So it is the gamma globulin component of the blood, the kind of immune component of multiple donors. And it's very expensive, and it takes a long time to get it. It's like this very thick, proteinaceous liquid that you get IV in an infusion suite, and it is sometimes given over the course of a few days. So it's a time-intense treatment, but sometimes helpful, at least in one small study. And certainly a consideration in myositis, where it's really been shown to be helpful more in cases that are recalcitrant or not improved with methotrexate or azathioprine. So medications to treat arthritis that we've probably all seen advertised on TV include tumor necrosis factor inhibitors. So these include Enbrel or etanercept, adalimumab or Humira, infliximab or Remicade. Some other newer ones are certolizumab and golimumab. These are approved by the FDA to treat rheumatoid arthritis and some other forms of inflammatory arthritis. And so they've been tried in small studies of patients with systemic sclerosis and inflammatory arthritis. And in some cases, it really did lead to improvement of symptoms. It was generally tolerated in a way that was similar to patients with rheumatoid arthritis. One patient who was studied in these small studies that I'm referring to did develop a lupus-like reaction, which is a described side effect. And we don't generally use these in lupus patients. Sometimes we do, but it can, they can lead to like a drug-induced lupus. With these medications, there's a risk of infection and TB reactivation. There's a potential, although not completely clear, risk of malignancy with medications like this. So these are all considerations. So if somebody had, if it was one of my patients who looked like a real RA overlap, I might think about these kinds of things. And even though they're not proven in scleroderma, we could, again, test to see if it helped that patient. Now, there are other biologic agents that are available that are being studied in scleroderma and for different conditions, not always arthritis, but these are medicines that are already on the market to treat rheumatoid arthritis. They're already approved, and they're being studied in scleroderma too to see if they're helpful here. So rituximab is one of those that is a anti-B cell medication, and that's given IV. Abatacept or Orencia is another medication that is currently being studied to treat early scleroderma with skin involvement, but this is, again, a medicine that is used to treat rheumatoid arthritis. And tocilizumab or Actemra, a paper was just published showing potential benefit for skin in scleroderma, and whether this would be something that could be useful in treating arthritis too is something that needs to be evaluated. But there's a lot of stuff out there already that's known, to be useful in rheumatoid arthritis. There's a lot of similarity, although they're not the same, similarity between scleroderma and rheumatoid arthritis. So there's a lot of potential medications out there that we really do need to study specifically for their effect in scleroderma joint issues. All right, so with that, I'm going to thank you for your attention.